Happy Thursday. What a great day for us to connect. For those of you defenders of the dechuser in the United States, happy July 4th. What a great day for us to kind of reflect on all our liberties and how do we come together to find solutions for the challenges we face, but we can do this. And I am hopeful. So moving on, an exciting week it's really been. I'm going to share a screen here real fast. It's been an exciting week. I think that it's great to see how academics and community urologists, with the support of the medical device industry, together we can come together and have a dialogue on LinkedIn about finding solutions about how to evolve forward the BPH BPO care pathway. And that is exciting. We tip our hats in appreciation to academic leader and stalwart defender of the dechuser, Nicolas Cornu from France, and his recent post in the French Journal of Urology titled Preoperative Urodynamics Still Has a Role for BPH Patients After the Upstream Trial. And we love this, right? Because we believe in data. We are big believers in Bladder Health Baselines. Using whatever urodynamic technology you have access to, let's get those Bladder Health Baselines for at-risk LUTS patients so that we can come up with a good plan to help save more bladders. With that said, as always, the morning tea quote today: just focus on being a little better than yesterday. The concept of incrementalism applies to ourselves as well as the BPH BPO care pathway. How do we constantly evolve it? How do we constantly improve it? Quick note, don't forget the ICS 2024 meeting is in Madrid. And look for that fantastic talk that's going to be coming, a keynote presentation by visionary defender of the dechuser, Paul Abrams, titled How Do Male LUTS Guide Our Management of BPO? Great stuff. As well as super honored to be part of the panel to present in Bucaramanga, Colombia, for the Columbia Society of Urology, in combination with the American Urological Association, with so many defenders talking there, such as defender Dr. Ricardo Gonzalez, the iconic visionary defender of the dechuser, Dr. Alan Ween. Such an exciting time for us to learn from all these great visionary defenders. And then if you have patients that may be candidates for clinical trials, find out more. Please go to North Shore Urology Research and learn more from defenders Alexander Glazer and Brian Helfand to see if your patients are candidates for clinical trials. And that's how we're going to consistently move the BPH BPO care pathway forward, is with good clinical research. And these guys are doing it for all of us. So thank you. Thank you all. And then next up here, trying to get the ManVsProstate manifesto out by the fall equinox. We're still working on the flow chart as well as the text and hiring an editor, so we'll get there soon. And it's been a fantastic last 2 months working with so many of you in academics in the community to really start to meld and find a supplemental perspective on male LUTS. On the left, you can see the classic, iconic spoken wheel male LUTS schematic seen in the European Association of Urology guidelines of 2024. And then working with all of you, putting together on the right-hand side, kind of another perspective for us to use as a springboard for discussion. You can see here in the middle, we're trying to really focus on bringing bladder health in as a centerpiece into discussion. On the right-hand side, talking about the contributions of BPH BPO, and not forgetting that there's so many other contributions to male LUTS, such as aging, and below that, neurologic dysfunction, pelvic floor dysfunction, metabolic syndrome, so many others, as well as polyuria. And as always, the BPH 360 podcast, hoping to get that launched over the winter solstice. As you all know, kind of delay that so we can get the manifesto out to all of you guys as soon as possible. So back to this fantastic post by Defender Cornu, and let's talk more about it. And moving forward, what we'll see here is how do we now blend academics and community urologists to come together as we blend evidence-based medicine with patient-centered medicine. And let's dive in now to his article in the French Journal of Urology. Preoperative urodynamics still has a role, and yes, we do believe that. So as we go over here, let's take a look at his article. As always, I just like to kind of scream, we believe in linguistic determinism. And if we're truly going to make bladder health a centerpiece of our discussions, we need to use the word bladder. And I just like to check and do a quick count. In this article, the prostate was mentioned 4 times, BPH 5 times, bladder once. And hopefully as our communication and dialogue evolves, we'll start using that word bladder more frequently to kind of bring it more into the forefront of our discussions and our minds. Moving down, just a nice introduction talking about the prevalence of LUTS BPH. As we all know, the term BPH, we aren't treating histology, we're really treating obstruction due to a tightening prostate or benign prostatic obstruction or BPO. And as a result, ManVsProstate has chosen to synergistically combine BPH with BPO, use them in combination because out there in the real world, urologists, men in the community, they recognize the term BPH now, and it's very pervasively familiar. So we need to use that, but we as academics understand that we're actually treating obstruction or BPO. So let's bring those terms together. I think that's been very helpful. Moving along down below, we talk about management here. Just a quick highlight, as you all know, part of that dialogue we're now having is, are medications really temporizing measures, not therapeutic measures? I think that's something we need to really think about. I think another element is, are medications actually not minimally invasive, but actually maximally invasive as they touch every cell in the body and affect multiple organ systems, creating systemic side effects throughout the body? And with that perspective, can we now relegate or reclassify medications as temporizing measures in the same group as, for example, a Foley catheter that temporizes the situation when a man presents in stage 4 retention in the emergency room? Then finally, you kind of move into decision for surgery. I think something that I'd like to just remind us all is that men, patients with BPH, BPO, every morning they wake up with their armor of masculinity, and I do not believe they are reliable witnesses to their bladder. And so it's really important that we find a way in shared decision-making 3.0 to allow 4 parties to come together to help make decisions about treatment and management, and specifically surgery. And those 4 parties are going to be the patient, the urologist, the healthcare system, as well as the bladder. And it's important that we help the bladder give voice to its needs and wants. And how do we do that? Well, we do that with urodynamics. That's right. Here we're talking in this article about multi-channel advanced urodynamics that was studied with the upstream study, and talking about the benefits that we should be thinking about with urodynamics preoperatively. And we love this topic. And the only thing we can add, please read through this article. He brings up some fantastic points. And I just want to reemphasize that 4 advantages of multi-channel advanced urodynamics is going to be the 4 Ps, right? With great quantitative data, multi-channel advanced urodynamics can be a great prognosticator, right? We can actually help predict outcomes. Guys who have true bladder outlet obstruction with good contractility are going to have better outcomes than those with weaker contractility. Or we can now begin to understand that urodynamics can also be a great preventer. That's the second P, prognosticator, preventer. With urodynamics, we can prevent unnecessary surgeries. 1 in 10, 1 in 5 to 1 in 10. Urodynamics revealed that a de-obstructing procedure is not indicated. And so we can be saving these patients from unnecessary surgeries. The third P, so we talked about prognosticator, the preventer of unnecessary surgeries, is also the planner. What's great about multi-channel advanced urodynamics with a filling phase and a voiding phase is we can now also begin to understand overactive bladder and looking for detrusor overactivity, or as you all know, stage 2 of the 5 stages of bladder health. Because now we can start to plan multimodality staged therapies to treat not just bladder outlet obstruction, but also overactive bladder. So great things that we've seen so far in the last years is the rise of doing, for example, botulinum toxin injections at the same time as a de-obstructing procedure for those individuals with severe storage symptoms, irritative voiding symptoms, whether it's urgent incontinence, urgency, frequency, and nocturia, right? Or potentially we can plan to do a de-obstruction and then be able to, in advance, prep our patients that they may need secondary staged therapies for their OAB or their urgent incontinence, whether that is percutaneous tibial nerve stimulation, implantable tibial nerve stimulation, sacral neuromodulation, or Botox as well. And then the last P is going to be a patient advocate. So we talked about the prognosticator, the preventer, the planner, and the patient advocate. If you dive into those other articles about the upstream, please read the quotes from the patients themselves. And you can see that in this modern era, patients feel relieved and reassured with this quality and quantity of good data from multi-channel advanced urodynamics, where they can feel reassured that they're on the right path, they're on the right journey with the right solutions from their urologist. And I think that's been very insightful for the 4 Ps and reasons why folks should really think about getting preoperative advanced multi-channel urodynamics if it is available to you. And so those are just some thoughts. I think it's a beautiful article, just really highlighting, yes, data matters. And if anything, let's continue to prioritize data for our guests. Let's prioritize shifting away from a drug-first approach to a data-first, pro-diagnostic, bladder-centric paradigm. So please read that article, just a great article. I'm so grateful for Nicolas Cornu for providing these insights. And then now what I'd like to just quickly talk about is just some final thoughts here. Just remember, the bladder is just so amazingly complex that it's not even transplantable, right? There's only 2 major organs that cannot be transplanted, the brain and the bladder. It is so precious. Let's take care of this amazing organ. And let's recognize that with data, we can begin to shed light into the window of curability for a man's bladder. And let's be thoughtful about finding the right time. It may not always be earlier, but the right time in the shared decision-making 3.0 process to de-obstruct a prostate when warranted. And I think that that is something we can all agree upon. Let's not wait and delay care beyond the window of curability where the bladder is irreparably damaged, potentially for the rest of a man's life. Here we talk about the shared decision-making process 3.0. Once again, not just the patient and the urologist, but also the bladder and the healthcare system should be participating in this process. This slide I think is important, which is we are really exploring through dialogue with academics and other community urologists, which is perhaps we need to rethink, quote unquote, what urodynamics might mean. And potentially it should be any test that sheds light and provides qualitative and or quantitative data about bladder health. And you can see here, we are subdividing it into basic, enhanced, and advanced. Because even the most basic testing, like IPSS on the bottom left-hand corner, the voiding diaries, uroflows, PSAs, 2D imaging with ultrasound can shed light on bladder health and detrusor function. The next level up would be enhanced, like penile cuff test or external condom catheter test, where we can at least get better data looking at pressure flow studies. And yes, we are missing the filling phase, but that is something we can get when available with advanced multi-channel urodynamics. And I just want to emphasize that cystoscopy is also a type of advanced urodynamics, providing qualitative data, shedding light on trabeculation, cellules, and diverticuli, bladder neck anatomy, prostate anatomy, shining light about bladder health and helping us make good decisions for our patients and with them in that shared decision-making 3.0 process. And here you can see just kind of a big diagram here, where if we allow the bladder to have a seat at the table of decision-making, on the left-hand side, you can see as we obtain a bladder health baseline in a perfect world, which doesn't exist, all of our patients could get a cystoscopy and multi-channel urodynamics, advanced urodynamics, and they could shed a lot of light. We can now subdivide patients based on, is there obstruction or not? Is it equivocal? Is it clearance obstruction? Or is there evidence of an underactive bladder or detrusor underactivity? And as a result, we can now allow the bladder to give voice to surgical choice, because obviously when there's clear obstruction or a hypotonic bladder, well, perhaps we should be looking at technologies in the category of invasive surgical therapies like enucleation, electrosurgical technology, aquablation, or potentially there are places that will do the most invasive therapies with higher risk, not necessarily high risk, such as robotic simple prostatectomies. But the advantage that these two categories all have is that they have the ability to maximally deobstruct prostates to allow the bladder to function at its maximum capacity. But recognizing one size doesn't fit all, we also have to consider the other elements in the needs and wants of the patient, the healthcare system, and the urologist. Recognize there are other issues to deal with, such as detrusor overactivity, urge incontinence, and recognizing that one size does not fit all, which Defender Cornu continues to teach us and guide us with as a guiding principle. And then with that, just remember our three mandates: to preserve bladder health, ending the polypharmacy epidemic, and preventing late-stage BPH BPO and end organ bladder failure. And remember the 5 stages of bladder health. That is a patient-facing decision-making aid, and it's an amalgamation of what we know as academics and as what we know as community urologists. And it's a way to communicate what are the consequences of choosing not to do something about your prostate when you could be putting your bladder at risk for these consequences of, for example, stage 2, detrusor overactivity, stage 3, urge incontinence, stage 4, acute urinary retention, and stage 5, a weakened bladder with detrusor underactivity. And then finally, how do we now just kind of re-envision the BPH BPO care pathway from a patient-facing perspective? In the bottom right-hand corner, we talked about this, medications. Is there merit to allowing them to be considered temporizing measures, along with catheters, for example, and temporary stents? Let's talk about a little bit more about a good age for screening asymptomatic men for bladder health. We've chosen the age 50 because we do believe throughout the world, each country will find the sweet spot probably somewhere between the ages of 45 and 55. Let's remember that at the centerpiece is all about preserving bladder health. Let's counsel our patients well. Let's triage them well to understand who needs bladder health baselines so that we can risk stratify them and help find a good surgical choice for deobstruction, for the right prostate, for the right patient at the right time within the window of curability as we use the shared decision-making process 3.0, considering not just prostate size and prostate shape, but also detrusor function. And so with that, we recognize here's the triangle of triage, where let's discuss what are the risk factors that would trigger a bladder health baseline. And we like to think of it as, an IPSS 8 and above by itself, or in combination with a Qmax less than 15 and or a PVR over 100, or a history of urge incontinence, or a history of spontaneous retention. Those could be triggers for a bladder health baseline where men are getting cystoscopies, plus, depending on availability, enhanced or advanced urodynamic testing. And as always, by doing this approach together, whether you're academics, whether you're in community or with the medical device industry, together we do come together as a common cause, a common fight on the front to save more bladders as defenders of the detruser. And thank you all for being those fighters on the front lines, and let's go save more bladders. All right. Thank you so much. We'll talk to you guys next week. I just wanted to jump on before tomorrow's July 4th holiday, and this is pre-recorded, and we'll put this out tomorrow for you guys, and I hope that's been somewhat helpful. All right. Have a great one. Take care now. Bye.